Hello and welcome. My name is Maureen Oscadal and I'm a registered nurse based in Seattle, Washington. I work here at the University of Washington Addictions, Drug and Alcohol Institute, or ADAI, as a nurse care manager trainer. I also work as a nurse care manager with the Harborview Medical Center office-based opioid treatment program. This video series covers foundational topics related to the role and work of nurse care managers who provide support to patients who are engaged in treatment for opioid use disorder. In this first video, to set the stage, we will cover a brief introduction to opioids, opioid dependence, and opioid use disorder. We'll get started now. So to begin, what are opioids? Well, opioids are exogenous chemicals that bind to neuroreceptors in our body, and they function like morphine, which means that they can relieve pain, they can cause euphoria, they can suppress cough, and they may cause constipation. Another effect that we are most concerned about is the depression of the breathing. And this is because opioids are central nervous system depressants. So they can depress the breathing center in the body, which leads to a risk of death in the event of an opioid overdose. And when we talk about opioids and the risk of opioid overdose, it's impossible not to address the topic of fentanyl. And by now, most of us are familiar with the term fentanyl, but what is it exactly? Well, fentanyl is a synthetic opioid, which means it's lab-derived. It's up to 100 times stronger than morphine and up to 50 times stronger than heroin. And prescription fentanyl is a Schedule II controlled substance that's prescribed to treat severe pain. Non-prescription fentanyl and related non-prescription synthetic opioids are very strong, fast-acting opioids that don't come from the pharmacy. And in these cases, there's really no way to know if a substance has fentanyl or another synthetic opioid in it, simply based on appearance, smell, or taste. And really, any opioid that's not coming from a pharmacy is likely to be fake and should be suspected to contain fentanyl. And there are some particular properties about fentanyl that make it particularly potent. First, it has a rapid and intense onset, and that combines with a relatively short duration of action, about 1 to 2 hours. These two components increase its addiction or dependence potential, and they also increase the risk of overdose. So since around 2015, fentanyl and other synthetic opioids have been an increasing part of the U.S. drug supply. And as of right now, in 2024, fentanyl and other synthetic opioids are the dominant opioids involved in opioid overdose deaths in the United States. As we've covered, fentanyl and other synthetic opioids are potent substances, which make them particularly risky to use, but there are many reasons why they have become the dominant opioids in the drug supply, and some of those are listed here. Synthetic opioids are lab-derived, which means they can be easier to manipulate or cut, and are cheaper and more efficient to produce than plant-derived substances like heroin, which relies on agriculture, a particularly resource-intensive process. Because fentanyl and other synthetics can be made in a lab, they can be produced almost anywhere. And while their potency increases the risks associated with using them, that characteristic can also be desirable, both for people who are using the substance and for people who are selling it. So as I just mentioned, fentanyl and other synthetic opioids are contributing significantly to the opioid overdose death rate in the United States. And in this graph, we see the impact of fentanyl and other synthetic opioids here in Washington state. In Washington, the rate of fatal overdoses from opioids has climbed substantially since 2015. And during this time, overdose deaths from heroin and prescription opioids in the green and the purple lines have trended downward, while the overdose deaths attributed to synthetic opioids has increased dramatically, and that's the light green minty color line that you see following the red line on this graph. And this is another way to view the same data. In this case, we're looking at the percentage of opioid overdose deaths by opioid type. Again, we see that non-prescription synthetic opioids like fentanyl, in this minty green line that's headed in the upward direction, are involved in a vast majority of overdose deaths, and that started around 2020. By 2022, nearly 90% of fatal opioid overdoses involved non-prescription synthetic opioids. So next, we're going to move into the topic of opioid dependence. And before we do that, I just want to note that it's important to distinguish between opioid use, opioid dependence, and opioid use disorder, because these terms are not synonymous. So first, we're going to talk about opioid dependence, and then we'll move into opioid use disorder later in this video. So opioid dependence is an expected physical change that occurs in the body as the body adapts to regular opioid exposure over time. It will happen to anyone who is taking opioids for a long enough period, and it is characterized by tolerance and withdrawal. Opioid tolerance means a person will need more of the opioid, a higher dose, to achieve the desired effect, either that being pain relief or euphoria. Opioid withdrawal occurs when somebody stops or reduces the dose of the opioid that they're taking. It is the physical sickness accompanied by psychological distress that people feel in these situations. And truly, people feel absolutely miserable, absolutely terrible when they're going through opioid withdrawal. This is a graphical depiction of what dependence can look like. So we have the acute stage of use on the left-hand side and the chronic stage of use on the right-hand side. During the acute stage of use, dosing of an opioid, as indicated by those black arrows, results in the desired effect, for example, euphoria or pain relief. But over time, with use of the same dose, that desired effect becomes less and less. When dependence develops with chronic exposure, eventually the person finds that that same dose of opioid provides no desired effect, but is in fact needed to avoid experiencing withdrawal. Next, we'll briefly touch on opioid withdrawal, which is a constellation of physiological and psychological symptoms that people with opioid dependence experience when they stop taking opioids. Again, most people find this to be a truly miserable experience. And the clinical opioid withdrawal scale, which is shown here, is an 11-item assessment that can be done by a clinician to rate some of the more common signs and symptoms of withdrawal. And the signs and symptoms listed on the cows include the pulse rate, sweating, restlessness, pupil size, bone or joint aches, runny nose or tearing, GI upset, including nausea, stomach cramps, vomiting or diarrhea, tremor, yawning, anxiety or irritability, and glue-flesh skin or piloerection. One of the most common signs of opioid withdrawal is increase in pupil size. This is not something that necessarily makes people feel very sick, but as a clinician, it's something that's easily observed. Of course, with opioid withdrawal, patients are often the experts. So if somebody is expressing that they feel like they are in withdrawal, it's important to believe them and to act on their symptoms. The cows can be used to determine the stage or severity of opioid withdrawal, which can be helpful for treatment of opioid withdrawal symptoms and may be helpful in evaluating the level of physical dependence. So now we're going to move into the topic of opioid use disorder, or OUD. An OUD is a biopsychosocial condition, which means it has biological, psychological, and social characteristics. The biological aspect is dependence, which we already talked about, that tolerance and the withdrawal. The psychological aspect involves preoccupation with or compulsive use of opioids. And the social aspects include negative impacts on important life activities and relationships as a result of opioid use, but it also recognizes that factors external to the individual contribute to their opioid use. And it's important at this point to highlight that most people who use opioids and most people with opioid dependence do not develop opioid use disorder. Opioid use disorder, or OUD, develops as a result of complex interactions between genetic and environmental factors, and we'll discuss a few of those now. So in terms of genetics, there is still a lot that we don't know in this area. There's much to learn, but we do know there are genetic factors that can influence an individual's vulnerability to opioid use disorder. These can include variability in opioid receptors, variability in dopaminergic tone and other neuroreceptors. It can also be variability in individual characteristics and personality traits, such as novelty seeking, risk avoidance, impulsivity, which is also a factor of age, and mental health conditions. We also know that the environment plays a big role, and that even in the presence of genetic predisposition, OUD may not develop unless certain environmental factors exist. Some environmental factors associated with OUD include parents, siblings, or friends' use of opioids, adverse childhood experiences or ACEs, trauma or stressors, limited positive experiences, untreated mental health disorders, and exposure to opioids themselves, whether it is from a prescription, from social networks, or another source. So now we'll talk about the opioid use disorder diagnosis. And again, it's important to recognize and emphasize that substance use, including the use of opioids, does not equal a substance use disorder. Substance use disorders are diagnosable conditions associated with these 4 C's: cravings, loss of control, compulsive use, and continued use despite harm. Opioid use disorder is diagnosed using the DSM-5 based on 11 criteria. An individual needs to have 2 or more criteria in order to meet diagnostic criteria for opioid use disorder. And here we see the 11 diagnostic criteria for opioid use disorder according to the DSM-5. And these are grouped into 4 main categories. Under impaired control, we may see that the person is using more opioids than intended, either in terms of quantity or duration. We may see that the person is unable to reduce or control their opioid use despite attempts. They may be spending a lot of time getting, using, or recovering from opioid use, and they may endorse opioid cravings. Under social impairment, we may see that use impairs the person's ability to fulfill major role obligations. They may be experiencing social or interpersonal problems that occur as a result of their opioid use. And they may be giving up important social activities in order to use opioids, or as a result of their opioid use. Under the category of risky use, we may see people using in risky ways or engaging in risky behavior in order to use, and people may be using opioids despite physical and psychological harm. And lastly, under the category of pharmacological symptoms, we see tolerance and withdrawal. And again, these 2 characteristics, these 2 symptoms, are what define opioid dependence. So these 2 alone are not enough to diagnose someone with opioid use disorder. They can be used in conjunction with other symptoms on this list, but these 2 alone only meet the criteria for opioid dependence, and you would need other criteria from this list to diagnose somebody with opioid use disorder. And according to the DSM-5, opioid use disorder, or OUD severity, is based on the number of those 11 criteria met. So a score of 2 to 3 is diagnostic of mild opioid use disorder. A score of 4 to 5 meets the diagnostic criteria for moderate opioid use disorder. And a score of 6 or more meets criteria for severe opioid use disorder. So that wraps up this first video in the series. In the next 2 videos, we'll review medications for opioid use disorder, or MOUD, which are the standard of care in the treatment of opioid use disorder. Thanks for joining me.